Now we will proceed to what are the important clinical pearls that we need to keep in our mind when approaching a patient with dyspnea. So essentially the sequence of history taking involves the going in a structured and a systematic manner. Whenever somebody complains of dyspnea or difficulty in breathing, we need to structure the history in this manner, and this is the sequence with which you are expected to present in the exam in front of the examiner as well. So the first thing that we generally ask is the duration of dyspnea, the onset of dyspnea, and the progression, how it progressed, like how the dyspnea was at the beginning and how is it right now when he is presenting in the hospital, or after presentation what is the progression, did it worsen or did it improve with the due course of time. Those kind of things are something that we expressed in the progression of that dyspnea. And finally what we have to also say is what are the sequence with which dyspnea comes. Is it consistent, is it continuous dyspnea throughout the day and night, or whether it is episodic, whether the patient is feeling breathless only during a particular time of the day, etc. And then we'll have to ask for variations. There are 3 variations that we ask: whether the breathlessness has a positional variation, whether it has a variation between night and day, that is diurnal variation, and whether the breathlessness has variation with respect to the seasons, that is seasonal variation. And in sync with that, we also ask about another complaint, which is orthopnea, which is in ideal terms a positional variation of dyspnea, and another milder variant of orthopnea, which is paroxysmal nocturnal dyspnea. And then we complete the history taking by asking what are the aggravating and relieving factors and whether the breathlessness is associated with any wheeze or not. This is how we generally structure our presentation. So I might present you a sample history. Let us say a patient, a 45-year-old patient has come with 6 months history of breathlessness, or maybe 2 months history of breathlessness. What I can say is breathlessness started 6 months back, and it has worsened for the past 14 days. It was an insidious onset, gradually progressive breathlessness, and initially the breathlessness used to be episodic in the fact that it used to be more during early mornings, and it used to there is no history of any positional variation. Breathlessness is more during early morning, and breathlessness also aggravates during cold climates, and there is no associated orthopnea or any history suggestive of paroxysmal nocturnal dyspnea. Or sometimes many of the conventional examiners might not be comfortable with using a medical term in the form of orthopnea or paroxysmal nocturnal dyspnea. In such a situation, you can present that there is no worsening of breathlessness on lying down. There is no history of waking up from sleep after 2 to 3 hours of going to sleep in the middle of the night due to breathlessness. And the breathlessness aggravated on exposure to cold climate as well as on exposure to cigarette smoke and to exposure to dust. And it relieved by taking inhalational medications and some medications which were prescribed for him when he visited his nearby primary health center. And there was no associated wheezing sound which was heard along with the breathlessness. So this is how we can present a sample history of breathlessness in a patient who complains of breathlessness. So because breathlessness is a complaint which is pertaining to both the cardiovascular system as well as the respiratory system, it is very important to differentiate between the breathlessness of cardiac origin and the breathlessness of respiratory origin. We do have other conditions which can cause breathlessness, but then the predominant differentiation is between the cardiac as well as the respiratory cause of breathlessness. Dyspnea is all about a ventilation perfusion mismatch. Ultimately, the tissues in your body require oxygen, and this oxygen is entering into the body through the respiratory system, and this oxygen is taken into the tissues by the cardiovascular system. So anything that impairs, that restricts or obstructs the passage of air into the respiratory system will cause breathlessness due to a respiratory cause. And anything that impairs with the perfusion, that is anything that slows down the passage of oxygen from the heart to the tissue, is a cardiovascular cause of breathlessness. So left ventricular failure is a common cardiac cause of breathlessness. Coronary artery disease leading to myocardial fibrosis and myocardial pumping failure is another cause of breathlessness due to a cardiac origin. Any obstruction in the airway or constriction of the airway due to bronchial asthma or chronic obstructive airway disease, or collection of pus in the airway due to bronchiectasis or pneumonia can be a respiratory cause of breathlessness. So it is very, very important to differentiate between the cardiac as well as respiratory cause of breathlessness in any given patient, because it will decide the direction in which your case taking is going to proceed, and it will decide what system case that you have got for your exam, whether it is a cardiac case or a respiratory case, or maybe a mixture, maybe having an infection in a patient who is already having coronary artery disease or valvular heart disease. But there are lot of differences which we can make out while taking history from a patient with cardiac dyspnea and respiratory dyspnea. Now, respiratory dyspnea is most commonly due to either an airway disease or a parenchymal disease. In most of the airway diseases, what happens is the predominant complaint or the earliest complaint that the patient presents is going to be mostly cough, because whenever there is an inflammation of the airways, the patient will predominantly complain of cough as his major complaint. So cough is a very, very important association in patients with respiratory breathlessness, whereas cough association is not so common in a patient with a cardiac problem. You can have cough due to left atrial failure in the form of mitral stenosis, etc. Or even in pulmonary edema, the late stages of pulmonary edema can present with cough, but cough in general is a very rare symptom in cardiac breathlessness. Now, cardiac causes of breathlessness are predominantly exertional, which means that whenever a patient tries to do some activity, then the breathlessness tends to increase. That is because whenever the patient goes on to do some activity, his metabolic requirements are increased. So what will happen? The cardiac output should increase. Now, cardiac output is stroke volume into heart rate. So in order to increase the cardiac output, generally the myocardium will have to contract with a higher force or a higher rate. Both of these conditions can actually worsen the ischemia in the myocardial muscles. So in a patient who is already had a coronary artery disease in the form of an myocardial infarction, what could generally happen is whenever that increased requirement of increasing the cardiac output is there, the body is not able to increase the force of contraction. Thereby, there will be an increased end diastolic pressure leading to congestion in the pulmonary circulation. So what happens is the pulmonary edema occurs, and that congestion can actually lead to constriction or mechanical pressure over the small airways, and that can also lead to a cough. So that is a mechanism of cough in cardiac disease. But this is very, very rare, and much before that they will be experiencing breathlessness because of the pulmonary edema. So exertion will increase the amount of fluid that is retained in the lung. So that will lead to increase in the heaviness of the lung, and with exertion the breathlessness of the patient will increase. So exertional breathlessness is a classical feature of cardiac dyspnea. Okay, so this is not a very classical feature of respiratory dyspnea. Obviously, whenever somebody is having an exacerbation of bronchial asthma or COPD, he might say that breathlessness is increasing at the time of exertion, which is very true. But the thing is, the triggering of breathlessness in a cardiac patient, the breathlessness can be triggered by exertion, whereas it is not so common in a respiratory breathlessness. You have one respiratory condition wherein exertion can trigger breathlessness, and that condition is exercise induced asthma. Okay, exercise induced asthma can be triggered by exertion, and breathlessness can worsen with further exertion. Okay, and in sync with that, what will happen is in a patient having cardiac failure, they will be generally having worsening of breathlessness on lying down, and that condition is what we call as orthopnea. Worsening of breathlessness in the lying down position. So this is also highly in favor of a diagnosis of cardiac etiology. You should also know that orthopnea could be seen in severe respiratory conditions as well, but it is very less likely. But a symptom which is of lesser severity than orthopnea is paroxysmal nocturnal dyspnea. So what happens is when the patient lies down, initially because of the compensatory mechanisms and adaptive responses in a heart, what could happen is there will be going to be an increase in venous return, and this increased venous return is partially compensated by the sympathetic nervous system, which will be activated, and that will lead to increased ejection, and immediately when the patient lies down they will not be feeling any breathlessness. But later on what will happen is when the patient goes into deeper levels of sleep, he is going to have more of a parasympathetic innervation, and the sympathetic stimulation is no longer compensating for the increased force of contraction and increased rate of contraction. So in such a situation there is going to be left heart failure is going to be manifested, and the patient will develop pulmonary edema after 2 to 3 hours of going into sleep. So after 2 to 3 hours of going into sleep, if a patient is suddenly waking up with breathlessness and then he stands upright in order to improve his ventilation, and he wants to take some breath of fresh air into his system, that symptom is what we call as paroxysmal nocturnal dyspnea. Now paroxysmal nocturnal dyspnea is 100% specific to a cardiac cause of breathlessness. So paroxysmal nocturnal dyspnea is something that we don't see in a respiratory dyspnea. And respiratory dyspnea, how do we go about respiratory dyspnea? It will be generally associated by cough, and sputum production is also a feature of respiratory dyspnea. So sputum production is something that is not seen much in cases of cardiac cause of breathlessness, except in cases of very high levels of pulmonary edema. When there is a severe pulmonary edema, you can have a pink frothy sputum in case of cardiac dyspnea. So a pink frothy sputum is something that you can see in cardiac dyspnea. So what happens is when the pulmonary edema increases in its severity, initially the fluid or the plasma that is exudating from the pulmonary capillary is going to occupy the interstitial spaces of the lung. Later on, as the fluid accumulation increases, this fluid is taken into the alveoli of the lung, and in the alveoli you all know that we have surfactant. So this surfactant has this property of surface tension. So when air comes in, fluid is also there in the alveoli. So this fluid is mixed with a detergent in the form of surfactant, and this fluid and air will mix this fluid and surfactant, and finally what develops is a froth. And even when the severity of pulmonary edema increases, there will be some amount of blood in the alveoli, in the exudate that is coming into the alveoli, and this blood along with surfactant and the secretions will ultimately give it a pink frothy appearance. So pink frothy sputum expectoration is something that we see in severe heart failure or in pulmonary edema, but otherwise 99 out of 100 cases of respiratory symptom generally is associated with sputum production, whereas cardiac dyspnea, if you take the majority of the cases of cardiac causes of breathlessness, sputum production is almost rare and not so common. The other condition, or maybe the historical point that you need to understand, is that cardiac breathlessness is generally relieved because it is caused as a result of accumulation of fluid and left heart failure. This dyspnea is relieved by taking diuretic injections or tablets. So diuretics like furosemide will actually cause some improvement in the breathlessness of a patient with a cardiac cause of breathlessness, whereas breathlessness in an obstructive airway disease caused by chronic obstructive pulmonary disease or bronchial asthma will be relieved by taking inhalational medications, which are mainly steroids and bronchodilators. So steroids will reduce the edema and inflammation inside the airways, and bronchodilators will counteract the bronchospasm which is occurring as a result of the episode of asthma. So a bronchodilator will dilate the airways and increase the air entry into the respiratory system. So somebody having breathlessness due to a bronchoconstriction will be relieved by taking a bronchodilator and a steroid, which is an anti-inflammatory and an anti-edema agent. So that is something that is very, very important. So you can ask the history from the patient that do you have relief of breathlessness by taking some inhalers, or have you gone to the casualty of a nearby hospital and taken some inhalational medications and did it give some relief of breathlessness? If the patient answers yes, then you can probably ascertain that you are dealing with a respiratory disease. So that is the one of the important differentiating factors that you need to understand with regards to differentiating a respiratory dyspnea and cardiac dyspnea. So these are the core points. There are subtle small points, but these are the essential points that you need to understand in order to differentiate between cardiac and respiratory dyspnea. Okay. Yeah. So after understanding that, the first thing that we ask is, what was the onset of breathlessness? Is it sudden in onset, or is it acute in onset, or is it a subacute onset of breathlessness, or did the breathlessness have a very slow, gradually progressing onset? So whenever somebody says there is a sudden onset breathlessness, that is breathlessness in seconds to minutes, that is 5 minutes back this person was absolutely normal, then the first thing that we practically always think is whether the patient had inhaled or ingested any foreign bodies. Because most often we see small children brought to the casualty, saying in a deeply cyanosed state, having a bluish discoloration of the hands and toes, generally coming with breathlessness. Most often they would have been given the history that 10 minutes back we saw the child playing outside, suddenly he is seen choking and breathless and all. This is very classical of a foreign body inhalation. Most commonly small children may swallow some stone or maybe some peanut, etc., and that will be stuck in their throat in a subglottic level, and that will cause sudden onset breathlessness. So sudden onset breathlessness in a child is most commonly aspiration or a foreign body that is stuck in the throat. That is the most common diagnosis that we see. Now, a conscious adult is unlikely to aspirate because we have a very good well developed mechanism that prevents the passage of food or even any foreign body into the lung. We have a very good pharyngeal mechanism that will prevent entrance of any foreign body into the lung. But this neurogenic mechanism may be very weak in case of elderly people who are bedridden, or people who would have had a previous cerebrovascular accident and having some brainstem reflex dysfunction, that is in the form of some bulbar palsy, etc. So those elderly females or males who are bedridden in your homes due to chronic cerebrovascular accident, etc., they are likely to aspirate foodstuff into their lungs and present with a sudden onset breathlessness. So aspiration is one of the causes of sudden onset breathlessness. Whenever you rule out aspiration as a cause of breathlessness, the immediate other thing that you need to ask is whether there was any history of trauma. Because if at all there is a history of trauma, sometimes an injury into the lung can directly lead to trapping of air in the pleural space. This condition is what we call as pneumothorax. So whenever there is trapping of air into the pleural space, this escape of air into the pleural space will lead to enlargement of the pleural space. So this pleura will be containing lot of air. So once when there is so much of air into the pleural space, what is going to happen is that this air will compress the lung and lead to collapse of the lung. So ultimately what happens is this air will accumulate in the pleural space. It has nowhere to go because during expiration the air might not leave the thorax. So the thorax will be filled with air and ultimately the lung undergoes collapse or atelectasis of the lung can happen. So this will lead to a sudden onset breathlessness. So pneumothorax is one condition that can cause sudden onset breathlessness, and whenever pneumothorax occurs spontaneously without any other stimulation, without any other trauma, etc., it is called as spontaneous pneumothorax. One condition in an adult male who is probably 20-25 years of age, one condition where they can present with a sudden onset spontaneous pneumothorax is Marfan's syndrome. So Marfan's disease is one condition which can lead to an increased instances of spontaneous pneumothoraxes. So a tall, lanky guy having Marfanoid habitus, if he is coming with a sudden onset breathlessness, you have to think about pneumothorax as a possibility. Okay. Now the next condition is acute onset of heart failure or pulmonary edema. Because whenever there is an acute myocardial infarction or an acute heart failure due to a very high BP, what happens in very high BP? Because when the blood pressure is so high, the peripheral resistance is also going to be very high. So the heart, the left ventricle will have to pump against a very high resistance. So it will have to increase the force of contraction. Sometimes a person who is having a weak myocardium in the form of previous myocardial infarction, what happens is the left ventricle will not be having that much power to pump that blood with that much force of contraction. So the left ventricle, if it fails suddenly, what will happen? All the blood will be pooled into the left ventricle during the end of systole, which also means that there is going to be a volume overload of that left ventricle. Sometimes in chronic patients with chronic hypertension, they may be having concentric left ventricular hypertrophy leading to a pressure overload also. So ultimate end result is the left ventricular end diastolic pressure will increase. So when the left ventricular end diastolic pressure increases, that will be reflected as a loading of left atrium. So there will be pooling of blood also in the left atrium. So left atrium do not have any muscles to contract. So only thing that it can actually do is it will undergo dilatation, and with progressive dilatation the left atrial pressure will keep on increasing because it is loaded with blood. So that will be reflected as an increased pressure in the pulmonary vein. So the pulmonary venous hydrostatic pressure will increase, then the pulmonary capillary hydrostatic pressure will increase. So pulmonary capillaries are very small leaky vessels having lot of pores in between. So when the pulmonary capillary stretches, the pores and all are exposed, and what happens is there is leakage of interstitial fluid, the fluid into the interstitium, and this is what we call as pulmonary edema. So pulmonary edema can cause sudden onset breathlessness in a patient who is undergoing some acute coronary event or a hypertensive heart failure, etc. Now the next condition that can cause acute onset breathlessness is occlusion of pulmonary artery by a thrombus. Not a thrombus specifically, an emboli, because a moving thrombus is what we call as emboli. So in a chronic long-term bedridden patient, an elderly patient who is having a cerebrovascular accident, having a left hemiplegia and not able to walk, they might be chronically bedridden in their homes, and because of that chronic stasis of blood in the venous system in the lower limb, they can develop deep vein thrombosis of the lower limbs. Now this thrombus can be suddenly dislodged from the saphenous vein or the femoral vein, and finally that can go in through the external iliac vein into the common iliac vein through the inferior vena cava, and ultimately it will reach the right atrium. From the right atrium, this emboli will go into the right ventricle, and suddenly when it enters into the pulmonary artery and into the pulmonary capillary, this will be stuck at some place. So there is going to be no perfusion to the point which is distal to the embolic occlusion. So that will lead to ischemia to that part of that lung, and may need to even infarction of that lung also. So this and that lung will ultimately not take part in the gas exchange also. So this will lead to a decreased perfusion to that lung, as well as an impaired ventilation from that part of the lung, because when there is no perfusion to that part of the lung, no gas exchange is going to happen. So effectively there is a ventilation perfusion mismatch, and this will lead to a sudden onset of breathlessness. So another condition which presents with a sudden onset breathlessness is pulmonary embolism. So pulmonary edema, pulmonary embolism, pneumothorax and aspiration are the major causes of sudden onset breathlessness. Now the other condition which can present with breathlessness in seconds to minute is anaphylaxis. Now let us see what happens in anaphylaxis. So in anaphylaxis, what happens is there is going to be diffuse bronchoconstriction and increased secretions in the airway as well. So because of most of the conditions leading to sudden onset breathlessness in anaphylaxis is because it is a severe form of allergic reaction. So it is like a condition which is 100 times worse than an acute episode of asthma. So they are going to have a severe bronchospasm, and also they are going to mostly suffer with laryngeal edema. Many a times we have had very bad experience in trying to even give some ventilation to patients having severe anaphylaxis. When we try to put an endotracheal tube, we have seen cases where the larynx is so much swollen that there is not even a single slit which is remaining for us to pass the tube. In such a condition, what we do is generally we will have to go out with tracheostomy, etc. Okay, so that is what one of the dreaded things that we fear when we see a case of severe anaphylaxis in the casualty. You will have to proceed with a emergency tracheostomy to open up the airway, because your endotracheal tube is not going to pass through the larynx in severe laryngeal edema. We have had very bad experiences in that regard. So you have to be aware of the fact that laryngeal edema is something that is going to be a very severe complication of a bad anaphylaxis episode. So anaphylaxis due to laryngeal edema will cause decreased entry and exit of air through the larynx, and severe bronchospasm will again increase the bronchospasm and bronchoconstriction, leading to lesser passage of air through the respiratory tract. This will cause so much amount of breathlessness to the patient, and anaphylaxis is one of the dreaded things that we fear in this condition. And one of the sudden out of all these conditions, the condition that can lead to the rapid death of the patient if it is not treated in an emergent manner is again going to be anaphylaxis. But then pulmonary embolism and pneumothorax and even pulmonary edema are all emergency conditions where you will have to be very vigilant and deal with the patient in a very rapid manner. Okay, so sudden onset breathlessness, I have mentioned the causes. Now, what are the causes of acute onset breathlessness? Now, acute onset breathlessness means breathlessness that evolves over a period of hours to days. So, somebody having a breathlessness for 6 hours or breathlessness for 2 days, 3 days, rapidly increasing breathlessness, you will have to think about these many conditions. The respiratory conditions that present with acute onset breathlessness, obviously there is an overlap between hyperacute as well as acute onset of breathlessness. Sometimes a submassive pulmonary embolism can present with an acute to subacute onset of breathlessness. A small pneumothorax can lead to a slowly evolving breathlessness which can evolve over hours to days also. And another condition which can actually cause acute onset breathlessness is pleural effusion. Now, pleural effusion means there is fluid, instead of air, there is fluid in the pleural space. So if there is fluid accumulation in the pleural space, again this fluid can mechanically compress the lung and lead to breathlessness to the patient. So this mechanical compression caused by fluid is something that can cause a subacute onset of breathlessness. Now you can have progressive evolution of infections in the airway. So whenever there is an infection in the airway, what can happen is there is going to be an inflammation of the airway, and because of the inflammation of the airway, there is going to be more neutrophils that are going to be in the infiltrate, and the inflammation will lead to more edema and more secretion of mucus, etc. There is going to be a lot of pus and all, and because of all these things, they could be having variable amounts of endobronchial obstruction because of the presence of sputum, mucus, etc. in the airway, and that could an infection and a pneumonia leading to a impaired ventilation is another cause of an acute onset breathlessness. Now, bronchial asthma is another condition which can cause acute onset breathlessness. Similarly, an exacerbation of chronic obstructive pulmonary disease can also cause an acute onset breathlessness which progresses in hours to days. What could be the cardiac condition which causes acute onset breathlessness? It is most commonly an acute onset heart failure or a cardiac tamponade. Now, cardiac tamponade is a condition where there is escaping of blood or fluid into the pericardium, and suddenly when there is filling of blood in the pericardium, that will mechanically compress the heart that will lead to sudden onset breathlessness because of the impaired venous return as well as left ventricular outflow from the heart, which is under an external stress by the fluid or the blood in the pericardial area. This condition is what we call as cardiac tamponade. Now the other conditions which could also cause acute onset breathlessness is acute respiratory distress syndrome. What do you mean by acute respiratory distress syndrome? Means you would have learned in pathology. It is basically a non-cardiogenic pulmonary edema wherein there is so much amount of inflammation happening in the interstitium of the lung as a result of some infections or some other agents, etc. It could be a pulmonary manifestation of septicemia also. So what happens in ARDS is there is going to be a lot of infiltrates in the parenchyma of the interstitium of the lung. So this interstitial accumulation of inflammatory exudates will interfere with the gas exchange across the alveolo-capillary membrane, and that will lead to an impaired perfusion of the capillaries of the pulmonary capillary, and that will lead to breathlessness in the patient. And now you know that the basic buffer system in our body is consisted of the kidneys and the respiratory tract. The buffer system operates predominantly in the kidney, the bicarbonate buffer you all know, and it regulates the acid-base balance in our body. So if there is some kidney disease or some other conditions which is causing metabolic acidosis in the form of diabetic ketoacidosis, etc., what can happen is there is going to be accumulation of lot of H+ ions in our body, increasing the acidosis. So one of the counter-regulatory mechanism is to balance out this excess of H+ ions by exhaling carbon dioxide into the atmosphere. So how can you exhale more carbon dioxide? Because carbon dioxide is the other acid. So the counter regulation of metabolic acidosis is respiratory alkalosis. Increase the rate and depth of breathing so that more carbon dioxide is exhaled out, and that balances the acid equation in our body. So whenever any condition causes metabolic acidosis, there is going to be a counter regulatory respiratory alkalosis. So we have talked about some acute causes of breathlessness. Now we will move on to some chronic conditions which can cause breathlessness. The most important condition that you need to know is chronic obstructive pulmonary disease and bronchial asthma. Both are diseases of airways. In bronchial asthma, there is a bronchospasm. There is a reversible airway hyperresponsiveness, and because of the hyperresponsive airway, because whenever there is a dust that is coming into our airway, our body will increase the mucociliary production of mucus, and because of the mucociliary clearance mechanisms, all this dust will be sticking to the mucus and it will be eliminated out. Whereas in a patient with bronchial asthma, if he is sensitive to that dust, what will happen is there is going to be an exacerbated or a exaggerated production of mucus, and a spasm of the airway is the end result. And because of the constriction and spasm of that airway, he will be having an obstructed airway. So asthma patient can have breathlessness which can be lasting from months to years, and chronic obstructive pulmonary disease is another condition which can present with a chronic onset of breathlessness. So these are the airway diseases which can present with chronic onset breathlessness, airway diseases. Now interstitial lung disease is another parenchymal lung disease, or an involving stiffening and fibrosis of the interstitium. So that will involve the interstitium of the lung and leads to a restrictive airway disease. So COPD and bronchial asthma are obstructive airway disease, in that it obstructs the entry and exit of air through the airways. And because inspiration is an active process, they do not experience much of a restriction or obstruction during inspiration. Instead, what happens is patients with bronchial asthma and COPD, because expiration is a very passive process, it becomes very protracted, and a very prolonged expiration is something that results. So in bronchial asthma and COPD, the obstruction is more predominant during expiration, and the duration of expiration is prolonged. That is what is one of the classical auscultation findings in patients with COPD. diminished intensity vesicular breath sounds with a prolonged expiration. That is something that we see. We'll come into details about that. And interstitial lung diseases, the interstitium is fibrosed, so it is not compliant. What happens is the fibrosed interstitium will not allow the alveoli to expand during the phase of inspiration. So when the alveoli is no longer able to inflate properly because of a fibrosed interstitium. Now this interstitial fibrosis is as a consequence of chronic recurrent inflammation as a result of that organic or inorganic substance. It can be chronic exposure to asbestos or silica, dust particles, etc. So we call it as asbestosis, silicosis, coal workers pneumoconiosis. If it is due to exposure to some sugarcane dust and all, we call it as bagasosis. Cotton dust, we call it as bisphenol, etc. So these are all occupation related or some other external factor related fibrosis and chronic scarring of the interstitium of the lung. So ultimately, when there is so much amount of fibrous tissue, the fibrous tissue will restrict the inflation of the alveoli. So the restriction occurs predominantly during the phase of inspiration, and patient finds it very difficult to take in air because of the restriction caused by the chronically fibrosed parenchyma of the lung. I hope you are understanding all this. So ultimately, restrictive airway disease is one cause which can lead to a chronic breathlessness as its main complaint. Now the next condition which can cause chronic breathlessness is an endobronchial growth in the form of a bronchogenic carcinoma. Okay, so there is a condition also called as chronic pulmonary embolism, where there is no total occlusion of the pulmonary vessel, but there is a partial occlusion of a long segment of pulmonary artery, and that is what we call as chronic pulmonary embolism, which can present with a chronic history of breathlessness lasting from months to years. Okay. Now the cardiac conditions which will present with breathlessness are mainly chronic congestive cardiac failure, pulmonary hypertension, valvular heart disease, and various cardiac arrhythmias. And most common arrhythmias which can present with breathlessness would be atrial fibrillation, which is what we generally see in patients with valvular heart disease as well. So for your undergraduate level, for an exam level also, atrial fibrillation and valvular heart diseases are something that you are going to see more often in your exams for your long and short cases also. So valvular heart disease and cardiac arrhythmias are causes of breathlessness. And a restriction in the expansion of the chest can be due to a restriction in because of a structural problem to the lung also, and it can also be due to an extrinsic factor like a kyphoscoliosis. So because of the abnormality in the shape of the spine, the patient can have a difficulty in positioning of the lungs. So because the expansion of the lung may be affected by a bending of the spine or a lateral or sideways curvature of the spine, that can lead to restrictive airway disease. So kyphoscoliosis is one condition which can lead to a restrictive airway disease, and that could also cause chronic breathlessness which is lasting from years altogether. Now diaphragm is the chief muscle of inspiration. 80% of the inspiration occurs because of the contraction of the diaphragm. So if there is a diaphragmatic palsy in any patient, that would interfere with the ventilation of the lung, and a diaphragmatic palsy in a patient could present with a chronic onset breathlessness. Now, how do you grade the breathlessness of the patient? There are various scales. We have Sherwood-Jones scale, we have a modified Borg scale, and the MMRC scale. Now, the widely accepted scale for your exam purpose is the Modified Medical Research Council grading of breathlessness, or the MMRC staging of breathlessness. But one of the easier methods to assess is a modified Borg scale, where you simply tell the patient to give marks out of 10 for the severity of his breathlessness. If the severity of breathlessness is very high, then we put a score of 9 to 10 if it's very severe, and if the score is less than 2, then we do not take it as a very significant form of breathlessness. Now, this is what we commonly use in the analysis of breathlessness in the history taking, the MMRC grading of breathlessness. You should know that there is something called as grade 0 also. So if the question in the exam is how many grades are there in the MMRC grading of breathlessness, we have seen a lot of students answer as 4 grades. No, it is not 4. It is 5 grades of breathlessness, because there is something called as grade 0. Now, grade 0 is there is no significant breathlessness in the patient except when he is doing some strenuous activity. So if the patient is jogging or running, etc., if he is feeling breathless, then we term it as grade 0 of MMRC breathlessness. Now grade 1 is if somebody is walking slight uphill, there is a small hill, or maybe walking briskly on a level ground. If somebody is walking with a higher pace on a level ground than his normal pace, he could be having an MMRC grade 1 breathlessness. Now what is grade 2 of MMRC? If a person walks slower than the people of his same age, because we don't expect a 65-year-old male to be walking at the same pace as that of a 25-year-old boy, or maybe a 15-year-old kid or somebody. So we don't expect that. So if somebody is walking slower than the people of his same age group due to breathlessness, and that person is forced to stop in between in order to get relief from his breathlessness, that is what we call as MMRC grade 2 of breathlessness. Now MMRC grade 3 is the person is not able to walk a distance of 100 meters. So when he walks for a distance of 100 meters, he has to stop and take some rest in order to get some relief of his breathlessness. That is MMRC grade 3. And MMRC grade 4 is breathlessness even at the time of rest and while doing simple activities of daily living, like trying to put on your dress, trying to eat, trying to go to the toilet, and even at rest if you are having breathlessness, it is MMRC grade 4 breathlessness. Okay, so this is the MMRC grading of breathlessness. Now once when you grade the breathlessness, why do you want to grade breathlessness? It is just to tell the examiner how the breathlessness has progressed. Okay, so you can probably say that my patient was having breathlessness only on doing exertional activities 1 month back, and for the last 1 week it has progressed to such an extent that breathlessness, initially he found it difficult to walk for even 50 meters, and for the past 1 day he is having breathlessness even while trying to put on his clothes or while trying to even eat. So that would probably say that maybe 1 month back the breathlessness was only MMRC grade 1, and in the past 1 week it has increased dramatically to the extent that it has gone up to MMRC grade 3, and now the breathlessness is MMRC grade 4. So the reason why we want to grade MMRC class of breathlessness is just to understand the progression of that disease, how rapidly that disease is progressing, or how worse this current exacerbation is when you compare it to the previous times. For example, when the patient was having a breathlessness and wheezing, he used to walk to the OPD. Now this person has come breathless into the casualty. So if somebody has come walking to the OPD, maybe we can prescribe him some bronchodilator as a metered dose inhaler, like a spray or a rotahaler, etc. But when he is brought to the casualty, not even able to sit, maybe even lie down flat, and having so much amount of wheezing, we may have to admit the patient, we may have to give injections of bronchodilators, steroids, etc. So the progression of breathlessness will tell you what the seriousness of that condition is and what is the rate of progression of that particular disease. That is the utility that it gives when you present that to an examiner. Okay. And episodic breathlessness is something that we generally see in cases of bronchial asthma and COPD, because they tend to be exacerbated especially during exposure to dust, toxic fumes, smoke, as well as on exposure to cold climate. So breathlessness is likely to be episodic in cases of bronchial asthma and COPD. But if somebody asks you what condition is the breathlessness maximally episodic, then your answer should be bronchial asthma. Bronchial asthma is one condition wherein the patient will be normal in between the episodes of asthma. He will be absolutely normal, and whenever he has that exacerbation, he generally tends to be having severe breathlessness. Whereas in a case of COPD, they will be having some amount of baseline breathlessness at all times, and during the episode of exacerbation, there will be worsening of the breathlessness. That is very, very important. Okay. So somebody having consistently grade 2 MMRC breathlessness now suddenly presenting with maybe 1 year history of grade 2 MMRC breathlessness and suddenly having grade 4 could be having COPD. Whereas a bronchial asthmatic patient might not be even breathless during the entire time when he is symptom free, or he may be having just maybe grade 0 MMRC breathlessness suddenly coming with grade 4 MMRC. That is one clinical clue that you can probably differentiate between bronchial asthma and COPD by history. Okay, in between the episodes, a bronchial asthmatic is going to be symptom free, whereas in between the episodes of COPD, the patient will be having some amount of baseline breathlessness. Because reversibility and all the other points is something that you cannot elicit by just a history alone. You will have to demonstrate using a pulmonary function test. Okay. Now, bronchiectasis is another condition which can be associated with episodic breathlessness, because there is chronic inflammation of the airways and dilatation of the airways in a case of bronchiectasis. So, that dilated areas or the bronchiectatic areas are going to accumulate lot of bacteria, and that will be leading to periodic exacerbations of bronchiectasis, and they will be having episodic breathlessness. Hypersensitivity pneumonitis is a form of interstitial lung disease wherein there is inflammation of the interstitium in response to certain microorganisms, dust and fumes, etc. So these are the conditions which can present with episodic breathlessness. Now let us move on to the conditions which can present with postural variations. Okay, breathlessness which is worsening or improving with a particular posture. Now the broad thing that you need to understand is if there is a pathology on one side, so assuming that a patient is having a right-sided pleural effusion or unilateral pleural effusion. So if this patient is having pleural effusion on one side of the body, generally what is going to happen is when he lies on that particular side, the irritation and inflammation of the pleura will come down, and generally when he lies, if I am having right-sided pleural effusion, if I lie on my right side, what will happen is I will be getting some amount of relief of the breathlessness, partly because the irritation between the two layers of pleura is reduced as a result of lying on that side, and partly also because the left lung will be able to inflate more and thereby giving me some relief of breathlessness. Okay, so breathlessness generally released by lying on the side of the pathology, and it will aggravate when I am lying on the opposite side. Okay, so that's a very common concept that you can actually have when you think about breathlessness. Okay, so breathlessness which is more on one side is generally suggesting the patient having pleural effusion or pneumothorax or probably tumor or some mass on that side of the lung. Such a breathlessness is what we call as trepopnea. So trepopnea is breathlessness on lying to one side of the body. So that is breathlessness increases on lying to the right side, breathlessness decreases on lying to the right side. They all basically indicate that the patient has trepopnea. Now, pnea means breathing. So orthopnea means the patient is able to breathe in the ortho position. Now the ortho position is the standing position. So orthopnea means when the patient is standing, he is able to breathe, which practically means that when the patient is lying supine, he finds it very difficult to breathe. So orthopnea means breathlessness worsening on lying down position. Now this is a classical feature of a left heart failure, because whenever there is a left heart failure, when somebody lies supine, what happens? When somebody lies supine, the venous return from the lower limb will increase. So whenever there is an increase in venous return, there is going to be more blood in the heart. And a failed left ventricle might not be able to increase the stroke volume, and it will not be able to increase the cardiac output. So all this extra blood and all this kind of fluid is going to get congested into the lung, causing pulmonary edema, leading to worsening of breathlessness. So orthopnea is a classical feature of left ventricular failure, but you should also understand that orthopnea could be a feature of obesity as well. Okay, so when somebody is morbidly obese, what happens is when they lie down, their diaphragm may lose its power, and what happens is the diaphragm will move upwards, and that will restrict the expansion of the thoracic cage, leading to breathlessness. So in a morbidly obese patient having orthopnea on lying down, you may be able to explain in the absence of left ventricular failure with obesity alone. But if the patient is having ascites, accumulation of fluid in the peritoneal cavity, that fluid, when they lie down, that fluid will tend to migrate into the thorax, and ultimately it can also lead to worsening of breathlessness. Diaphragmatic palsy and pericardial diseases can also be causing orthopnea to the patient. So orthopnea is breathlessness worsening on lying down position. Platypnea is breathlessness worsening on upright position. So when the patient is standing in ortho position, he will be having breathlessness. When he is lying flat, or maybe you can replace flat with PLAT. So when the patient is lying flat in the supine position, that patient is comfortable. So in a platy position, he is able to breathe normally. In a supine position, the patient is able to breathe normally. When the patient stands up in the ortho position, he basically desaturates, which is one of the reasons why this is also called as, platypnea is also called as orthodeoxia, because he deoxygenates in the ortho position. So when he stands up, he deoxygenates, and when he is lying flat, he is able to take a normal breath. The conditions that basically cause this kind of a presentation is a left atrial myxoma and a complication of liver cirrhosis, which is called as hepatopulmonary syndrome. And a thrombus, a ball valve thrombus in the atria can also lead to a presentation as platypnea. Okay, so these are the three main causes of platypnea. Now there is a newer terminology which represents worsening of breathlessness on bending forwards, and sometimes the patient will be able to take breath when he bends forwards actually. That is what we call as bendopnea, and bendopnea is a feature of left heart failure again. So left heart failure can lead to orthopnea and bendopnea, and these are the conditions which summarizes the causes of breathlessness with varying postures. Okay. Now breathlessness in the conditions like asthma and all can be exacerbated by exposure to allergens in the form of dust, cold climate, and to pollen, etc. And breathlessness in COPD is generally exacerbated by exposure to cigarette smoke. Okay, and if the patient is a drowsy patient having poor level of consciousness, the patient is drowsy or in a stuporous or a comatose state, the patient is likely to aspirate food materials or even saliva regularly into the respiratory tract, and aspiration could be a cause of aggravation of breathlessness in a chronically bedridden patient. So these are the factors that could aggravate breathlessness in various different conditions. Okay, and the relieving factors, if the breathlessness is of cardiac origin, etc., then the breathlessness could be relieved by taking rest itself. But if it is due to a bronchospasm or a bronchoconstriction, as in the case of chronic obstructive pulmonary disease and bronchial asthma, the breathlessness will be relieved by taking inhalational medications. So inhalational medications are generally bronchodilators in the form of beta agonists. Okay, and anticholinergic agents. And one simple point that we need to understand is breathlessness in COPD better responds to anticholinergics, and breathlessness in bronchial asthma responds better to beta agonists. One of the reasons what they postulate is that COPD is predominantly a disease of large airways, because COPD preliminarily involves the major bronchus and the major bronchioles, and bronchial asthma is a disease of small airways. Your large airways have a high concentration of cholinergic receptors, and small airways have a high concentration of beta receptors or the adrenergic receptors. So beta agonists will give better relief to the asthmatic patient, and anticholinergics will give better relief to the patients with COPD. That is one point that you can note it down. And we have a few indicators of severe dyspnea. So if the examiner asks you, what are the indications of severe breathlessness? Then you will have to say the following, that is inability of a patient to complete a single sentence. If a patient is not able to speak a complete sentence without having breathlessness, that indicates that he has a severe breathlessness. And if the patient is already having tachypnea, an increased rate of breathing in sync with the breathlessness, then the patient is said to have severe breathlessness. And if the patient is not able to sleep because of the breathlessness, or if the patient is having cyanosis. Now you know cyanosis means bluish discoloration. So that bluish discoloration is due to the increased presence of deoxyhemoglobin, and that generally indicates a type 1 respiratory failure. So these are the indicators of severe dyspnea to the patient. So that completes the symptom analysis on breathlessness